Started. We had a little technical difficulty, but I think everything has been solved now. It's really my pleasure to introduce my friend, as well as colleague in global pediatrics, Dr. Kroupina, Maria Kroupina. Maria grew up in Russia. She completed her master's degree at Moscow University before moving here in 1995 to do her PhD at the Institute of Child Development here at the University of Minnesota. But while she was studying for her master's, she focused at that time on the early assessment of emotional regulation issues in young children with chronic health conditions like asthma. In addition, during that time she trained in family therapy and child psychoanalysis. After coming to Minnesota and beginning her PhD here, her research began to focus on understanding how early adversity, as Maria says, gets under the skin of a child and puts a child's neurodevelopmental potential at risk long term. In her postgraduate work, Maria continued to focus on studying the impact of early adversity, and through her collaborative work with colleagues here in pediatric medicine, she studied the impact of stress on the hypothalamic pituitary adrenal axis, a stress-sensitive system. She became particularly interested in developing tools to identify young children who are at risk for emotional dysregulation and social communication problems. Maria was awarded a fellowship in a program entitled 0 to 3, which is a national nonprofit organization that brings together experts who are working in the area of early child mental health. This fellowship allowed her to develop a research-based mental health program for internationally adopted children. At first, she was focused on internationally adopted children, but now she is expanding. She has been and continues to be expanding this knowledge and expertise to a larger population of young children who are at risk. She's presented her work at national and international meetings, and today she's sharing the details of her research as well as her clinical program with us today. Thank you so much, Maria.
Maybe we'll walk this way. Can you hear me? Is that okay? Cindy, thank you very much for introduction. It's a pleasure to be here, and I'm particularly excited to talk about the program that, as Cindy said, we are starting to expand, and for this part of the program that I'm talking today, we got support by Masonic gift to the Department of Pediatrics. That's a huge recognition of the work of many of my colleagues here at the Department of Pediatrics at the Center for Neurobehavior Development, to learn about the importance of early development and the risk factors for neurodevelopment. And also for me, on a personal level, and I want to bring a story of a little boy that I saw recently in my clinic. This is not his picture, but the picture just reminds me of his face. He has name Sam. He is 18 months old, and he actually didn't come for assessment with me. He came with his younger brother and his foster mom, and he was standing and really quietly observing. By the second time I met him, I started to notice that he's really not exploring the toys. He is not responding to different noises or different things that you can think can be really stressful for a child. And I start to ask mom questions. What's going on with Sam? Well, and she said, you know, like, I also checked with my pediatricians, and I want to know, I think something is going on with him, but I'm not sure what. And she told me the story that he was removed from his biological family. He had major, at that time, health issues, placed in the hospital. And that's created a significant, you know, like, threat to his health and also mental health. And what I want to say, for me, is particularly exciting that we can start, and I hope I will be coming to the story of Sam and trying to explain what we are learning and how we can address the needs of these children like Sam, who are not verbal, who cannot show us their pain, and sometimes really easy to miss. That's why I'm excited. For me, it's a really exciting time, because I hope with the help of this gift, we will be able to help more of these children. Today, we first will start to talk about why 0 to 3, why this particular time is special for child development. Then we talk about early adversity or toxic stress and why it's dangerous for brain development, neurodevelopment, and why it puts child, particularly at 0 to 3, at risk for long-term problems. We will talk about what early mental health is, why is this mental health program is different, and what areas we need to address when we talk about the early mental health assessment. We will talk about the summary of the program, and I will go about the who can be referred and what particular behaviors medical providers can consider as red flags in order to refer to this program. I will also talk about the future directions, and hopefully we'll have some time for questions. Definitely a lot to talk today. I'll try to be fast. The problem that we face now, that most of the, and I'm sure my colleagues who are working in mental health know that we see majority of the kids when they are school age. Challenges rely mostly in the challenges in recognizing the symptoms, like as I was talking about little Sam, how it looks like when a child really significantly affected by early adversity. Parents heavily rely on school assessment, or on the issues when come up at school system, and not as much ask the question when children are younger. I think that's coming to definitely disagreement with what we learned in the last decade about the brain development. We learned that when we think about the genes that give us only a blueprint, the connection built through experience and environment determines how these connections are built. That this environment has a lasting impact on architecture of the brain. And the most important, that this building of the brain go through the sensitive periods. During this sensitive period, the impact of environment particularly critical. I suspect many of you seen this slide by Chuck Nelson and his colleagues showing the different periods of brain development. And I don't want to go over the details. I just want you to pay attention to that, how many areas we take 0 to 3, how many areas going through sensitive periods, meaning the extensive development of these areas of the brain, meaning they also open to environmental influence, as bad as also good in terms of we think about the intervention. The part that also started to develop and get big attention in the recent years is development of high cognitive functions. We call, the executive functions start to develop in this period. And there is a really big trend in developing the intervention addressing these issues, because children with executive functions having problems in school, it's difficult for them to learn. But important to understand that this period starts already 0 to 3 and builds on child's capacity to hold emotion, to respond to stress. For example, the areas of the brain like amygdala developed by 18 months, with the child's ability to respond to stress, be sensitive to stress, develops quite early. And if we not address these issues early, to build on this, the developing of the high level skills is much harder. When we talk about the environment, what is environment when we talk about the young child, and what is environment and critical components of this environment that are promoting building healthy brain, healthy connections during these sensitive periods of time. I hope it will work. Yeah. I will show you video. Many of people who here in the room relate to mental health may see this video. This is called a still face experiment, and you see the normal interaction between parent and child. And what I wanted to point here, this is how many times this little girl had this normal interaction with her mom, correct? And it's so beautiful. It's like dance. She smiled, I smile. And this really creates the normal, optimal environment. Here, look, the experimenter asked mom to turn and make a still face, not smile, not respond to a child. Please look on a child. What's happening to this girl who really used to this, dance? For her, it's really dramatic. She's trying to engage her mom, and she learned that if she can be active, she can do it. You can see that quite a few tools over this period that they found with mom. She knows there are some games they could play. But it's really disturbing for her, correct? It's something really critical that is missing. And then it's coming to distress because it's so unusual and it's so stressful. What I want to definitely, in this relationship, you can believe that it will take a minute for them to get back to what they are usually doing. But what I want to say, how many children live in the environment that still face, correct? When we talk about the most severe deprivation, we talk about institutionalized children, or we talk about children with mothers who have depression or other mental health issues. We talk about the children who go through, transition, divorce, when parents just not available. And for me, this kind of makes, definitely on the ethical side, we cannot show our clinical slides, and I cannot show you how it looks like but it definitely creates a different organism. The child doesn't have this dance, and it's what we're learning now is creating a different brain. It's creating the connections that are not as healthy. Building relationship is in our biology, and we really need responsible adult for a child to grow up healthy. Special relationship develop with caregiver, and this relationship help regulate child emotions and learn self-regulation. This relationship built over the first 12 months. Okay, we need many of these interactions in order to build this relationship. And that found, I don't have time, but there's a wonderful research on on understanding how it's critical for building up the brain. If we have a missing part, we have a long-term consequences like this. When we think about this, that by 12 months, this special relationship, we talk about attachment relationship develops. I really like this slide because it's so simple. I could talk about attachment for hours, and here I just point, and hopefully it will be clear. Why by one it's really helpful for human child to have attachment? Because then it allows child to explore, somebody at my back that can go and explore the world. If a stressor comes, child come and seek for help, release emotional distress, make the connection, ready to go. We have children who you can think about that's every day, correct? That's what children do. They come, they go, they're ready. Teenagers do it differently. They text, they not come, they may call. But that's a healthy environment for the brain development. It's not a possibility if child doesn't have it to create a healthy brain. If we think about the Sam that I was just giving you example, he couldn't explore, he was freezing, correct? And he was not coming for help. Both of this side for him was disturbed. And if we understand and we have a concept of this as a really dangerous condition, that will be important to refer to families like Sam and his mom. The part that really exciting in the last couple of years, there are several interesting publications in pediatrics, great publications by Jack Shankov and his group from Harvard about understanding of early stress and impact on brain development and how it has to change the way we think about pediatrics. And I think the message are pretty clear that in pediatrics to understand that this is not only some event in child life, it can put at risk both neurodevelopment and health development of a child, and we need somehow to respond to the needs of these kids who did go through toxic stress. I really like their definition. Clinically, it's very helpful. I think to think about different levels of stress. I will go fast through this because the stress is not really a negative event. You know, we all know, you know, it's helpful for us when we present to be a little bit stressed because we talk better. We, you know, like we think fast. You know, there's a lot of advantage, and this is a positive stress. When we think about tolerable stress, is the stress that, if from the standpoint of a child, for example, first day in new school, correct? Maybe no fun, but my mom is meeting me at the door, or my mom will wait for me, or correct? There's a challenge, but I can tolerate this. When we talk about the toxic stress from the point of child, in particular thinking from 0 to 3, it's when the stress happen and there is no buffer between a child and a parent. For example, I have experience working with the children who were adopted from Haiti after earthquake. And there's a completely different experience when I have a little kid who had possibility to be with adults, caregivers or parents during the earthquake. Because it was manageable, it was scary, but the child was getting some protection. And I was working with a kid who was 2 years old on the streets for 2 days. That's toxic stress because brain not ready to get this experience. And what we are learning that it has long-term consequences. For the normal response to stress, we see all these physiological changes in blood pressure, in the heart rate, and immune system. When toxic stress, we see this for a prolonged period of time. Systems stay activated. It leads to disruption in brain architecture. It leads to health issues such as insulin resistance related, found to be related to toxic stress. It has a negative impact on metabolic system and immune system. Talking about the brain, toxic stress also has a negative impact on architecture of the brain, particularly on the areas that are sensitive and go through sensitive periods of development. We see a difference in neurons architecture and negatively impacting important functions such as ability to regulate stress and adapt behavior to different challenges. This is a slide that I think pretty clearly showing this is a normal neuron, and here we see neuron that related to experience of toxic stress, and definitely we see a much less connection and more damage neuron on this picture. When we studied children from institutional care, we also found that, I will go fast from this slide, when we study a stress-sensitive system, usually it's cortisol high in the morning, low in the evening. When we study children from institutional care, and we expect for the normal development child around 0.4. Here we, at adoption, we saw really low. It's a little bit increased over the period of 6 months. Again, early deprivation, toxic stress put at risk stress-sensitive system that known can damage many parts of the brain through the development and put child at risk. In summary, what we are just talking about, that the period of 0 to 3 is sensitive period when we need to, from the standpoint of understanding that plasticity during this time can be cutting both ways. One is in a positive way because a child is very open. If we think about this video with this mom, this child is getting all in, correct? It's an education, it's a stimulation, everything is forming the brain of the child. However, if we think about the child who did go through the toxic stress during this period, it also has more damage for the sensitive areas of brain development. And this is definitely a message for intervention. Intervention that particularly being known helpful in this time through research data related to nutritional intervention and also relationship intervention, helping parent to recognize child needs and establish a healthy relationship. Now I will be talking a little bit about what is specific about when we talk about building a program for early mental health for children 0 to 3. For example, you're familiar here at the university. We have a wonderful neuropsychological program. We do have program for children with autism. Why? Because they require additional assessment of the areas that are particularly affected by their condition, and then in their assessment they're particularly looking on social communication skills. For what's been shown over the years, and that's probably in the mental health the most recently emerging new domain is as for research and for the clinical work, but now really widespread in the United States, that people who work in the field, they require special training. When we talk about intervention for this group, we definitely think more about preventive intervention. I really like what the Alan Stroff, the professor at the Institute of Child Development, when we're talking about developmental psychopathology, we're really talking about, he stressed that about the initially is a problem in the relationship and then psychopathology of the child. That's why that's a very, very different approach, because in this approach we are looking not only on the child developmental status, but also on the status of relationship and status of environment around the child. We definitely, because it's such a tremendously fast changing organism, we have to think about the trajectory of development when we think about building the programs for the 0 to 3 group. And again, addressing not only the changes in the child, but also changes in the caregiver. I will expect, just by reading the literature and being at the conference, there is an interesting trend, which is, for me as a clinician, makes a lot of sense. I think there will be, in the future, we'll see much more interest in building regulation capacity for a parent. And I would, people who are working, for example, with NICU group children, premature low birth weight, may experience that regulation capacity of a parent are really critical when we are talking about special child, about child who needs a special help. And I think that would be an interesting development for this field. And definitely the major focus of intervention is on relationship. When we talk about toxic stress, as I was talking about Sam, the problem, the biggest problem, that this child will not sit across the table and talk to us. This child is not easily to understand by parents, because do you remember this mom was saying, yeah, he's somehow different, but but then she said, but he's okay, he's not making any troubles. Correctly, it's out of her radar in this sense. When child coming to pediatrician, it's not a sick child. Again, we are missing those components that what is it and how we can define this. The unfortunate part where we are now in terms of the toxic stress, we don't yet have a clear marker of how toxic stress is expressed in the brain. For example, I talk about cortisol. Definitely a wonderful marker for us as researchers, for example, to see if intervention works, if adoption works, and we see the improving in the functioning of the system. However, clinically, it's not yet a helpful instrument for us. That's why when we start to think about this, what are the possibilities for us as a community, and pediatricians, I believe, are really upfront people who are seeing these families through the first years, and maybe the first specialists who will be able to identify these problems, really start with thinking about the list that they need to go if this child have anything like this, like including abuse, neglect, deprivation, stressful transition, multiple hospitalizations. I very interested in this. I hear a lot, have some patients. We don't have enough research, but I suspect it can be also stressful for a young child, because during this time we're particularly looking at an experience when adult was not able to buffer the stress, correct? The child was going through the painful medical procedures or were separated from adult a period of time. That marks for us as a providers, that's something that we need to consider as a high-risk child and consider referring child for additional assessment. It's definitely not the comprehensive list, because I think the major idea I want to pass is that any experience which is stressful when child don't have this buffering experience is important, correct? Because you maybe in your offices will see something else, like losing a parent, maybe stressful divorce, other possibilities of the stressful events that will constitute you thinking, yes, I can put a red flag, this child did go through toxic stress experience. When we talk about the red flags for child behavior, again, if a child just went through the toxic stress, is a possibility to refer. Definitely, it's a safe way for us to go. However, if we want to think about who particular kids who will benefit of referral for additional services, the kids as Sam who are not looking for help, that would be the group are really we need to consider a high risk, and I will talk about this in a little bit. Children who show a very disinhibited social approach. Both of these are easy to see in pediatrician office, because during the medical exam, correct, definitely it's a big stress for a child. It's unusual, you can see how child is looking for parent help, or pushing parent away, or doesn't signal any need to be together. We same with social disinhibition. We do see easily in the pediatrician's office this behavior. And also motivation to explore. If child is frozen, you do see these kids are not only just shy, but you see a really severe response to novelty, no exploration. And decrease in communication skills. I will go over this in more details. when we talk about the disturbance of relationship, we're talking about the not ability of child to show distress and come to anybody for help. This is extreme on the continuum, and for us as a mental health provider, we have to diagnose child with attachment disorder. It's a very complicated mental health category. Over the years became very unclear, and I will try to be really short, but make you aware where we as a field. This condition exists in a small number of children who goes through severe deprivation. It can be foster care, institutional care, who even placed in a new, better environment, continue to display this behavior. Withdrawn, not emotionally connected to their parents, minimally seeking any help from them, and not responding to comfort. In very emotions, you will see very low positive affect and no, initiation of interactions. It's important to say that this condition can be diagnosed only closer to 1 year, because attachment relationship develops only at 1 year, because that condition can be diagnosed earlier. Why it's so important, and I want to bring, it's really rare, but this condition is not safe for child's life. People who are working with these children, I have a patients, 2 who are running on the streets, who are jumping from high places. There's no sense of danger. At this point, referral really important, and it's really emergency. If you to any degree suspect that a child who have a history of early deprivation, no showing any sign of connection to their caregivers, refer immediately, because it can put child at danger. We also hear about this terrifying stories, parents also killing or accidentally abuse in the families, killing young children. This condition rare, but it's important for providers to be aware of this. I do see this as a spectrum. We have much more kids who inconsistent in signaling their needs, and their parents also need help. You can see it in the office. You may have questions, but this is a good reason for referral. The other category now in DSM, we have different category for the disinhibited social engagement disorder. It's not considered the attachment disorder anymore. This condition is less threatening to a child's life, but what we know is that the children who have a reduced capacity to hold their impulses when they're in a social context. Well, they like to touch people, they approach new adults without any waiting for being invited. That's very easily, if providers see it in the office, it's pretty easily identified. The reason for us to know about this condition, it's again pretty rare, but this puts child at risk for long-term mental health. It's not something just disappeared, correct? These kids again need help, and usually it comes with a severe neglect or deprivation, multiple foster care placement or orphanage experience, but that's something also to be aware. As for children with autism, we found in our research that children with neglect and deprivation history show significant deficits in their social capacity to be engaged in social interactions. Here, for example, you see a child really healthy, not taking the toy, but looking on the person and sharing information. Here is also, and always with this we see a lot of positive effect. Children who experience toxic stress and deprivation often show problems in this domains, and this needs to be addressed again early on. If you think about 0 to 3 and developing on all this circuitry in the brain and how important a communication, we cannot wait until a child 5, 6. This needs to be addressed early. And again, during the visit, there is an opportunity to see how child responds, how child making eye contact, and how child engage in social communications. When we think about disturbance and self-regulation, is no surprise, correct? The video which I showed you about the interaction of little girl and the mom, it's a beautiful regulation, correct? This is not the girl is doing it, it's mom helping her. Now she is more active, but this is a dance that helping regulate her not to get too high, not to get too low, stay positive. There's a lot of things going on in the small moment of a connection between a parent and a child. Of course, if you have no experience of this, the self-regulation at risk. And exposure to toxic stress put a child to severe problems in this domain. The behavior problems in children who experience toxic stress, and parents can experience the frequent meltdown, tantrums, difficulty controlling emotions, extensive sleep problems, increase in fear, anxiety, easily can be overwhelmed, aggressive toward parents and other children, overly active, in this, aggression and overly active behaviors. It's very interesting. In the population that I work, toxic stress, you often see underlying enormous fear. But on surface, these behaviors may look really disruptive. This is very typical. Again, probably there would be other possibility. When I was coming, I was thinking about eating problems. Problems with food is another typical issue for these children. But it could be some other issue related to regulation. Why? Because the environment really didn't provide this dance, correct? Or it was a disruption, or it was a prolonged time of when the child didn't get any normal social interactions. That can constitute a reason for referral, because by now what we learn from our research on brain and development, we don't need to wait 20 years. By now we already know that these children will have long-term consequences, and at this time when we know when we can help, we can change the circle and provide child with a more positive developmental trajectory. Okay, for the program that we are starting, the major goals is to provide assessment and therapeutic intervention for the young children, focus on eliminating the gap that exists for children 0 to 3 particular, and this was really important point, starting with the children who experience toxic stress, because this population is particularly at need. Capitalize on sensitive periods of brain development, because by understanding the brain and by understanding in what period of the brain this particular child is going, we can design a more sensitive intervention programs, and addressing multiple risk factors that this child facing during the years. When I was talking about this program, I got several questions about how it will look when the child would be referred and what it will be constitute for child in terms of assessment. This is 2 visits for a family that include both assessment and intervention component. I did put the photos that family allowed us to keep on our website about one of our visits. It's include the parent structural interviews, structural observation of parent-child interactions, and assessment of child communication skills. For some children, we also include full assessment of developmental assessment, but it depends on where the child, in terms of the post-adoption and foster care. We decided on the timing when the development assessment will be occurring. But the major idea is to address, is the environment that child lives is appropriate, is the parents can understand child's signal and can provide what child need to overcome the effects of toxic stress, of deprivation. It's very difficult, if we will come to the story of Sam, to for mother to see if a child standing in the room holding a finger, to understand that this child really needs her. And that's part that the most important piece is for parents to start to see what this behavior means and how I can help my child. Because what this experience of toxic stress, when child doesn't have a buffer, child learn to protect, to take care of all need by him or herself. Correct? I don't need a parent. It's a really kind of not good a place for 1-year-old, 2-year-old, 3-year-old to be. And we need to help mother to start to recognize how these needs look like and how we can help this child to learn again, to let it go, to open up and show the needs and work together with mom toward the progress of building this relationship. And the second part of intervention and building regulation capacities. It's easier to say than to do, and I'm sure that people realize it, because for many high-risk children we have prenatal exposures in combination with the postnatal risk factors for this high group. But however, I'm thinking about my 2 patients who one patient with medical problems adopted about 24 months, and I saw them in the clinic soon after with extensive sleep problems and anxiety. We were working exactly on this model, helping mother and father to understand his signals, then working on anxiety and helping him to feel more secure to enter the world. Now he is in the kindergarten, successfully learning, and definitely has regulation issues that we continue to help him to deal with. This is one scenario. I have a child, if I will compare their early history, almost identical, adopted at the same time, also with medical problems, coming to us at 11 years old, correct? At that time, parent thought, okay, he has sleep issues, anxiety issues, it may be okay. It 11-year-old child, it's not true that we cannot help. We always can help. But we're already dealing with the significant peer interaction problems, very damaging relationship with parents. Parents are really hurt by him because he's so aggressive and so, like impulsive in his behavior. Now he's on several medications, he's seeing his therapist, I'm helping his mom kind of to go over the relationship issues. It just, it just night and day in terms of effort for us as a mental health community to help early on, or to help when children particularly become close to teenagers. It's always possible and we always have to do it, but I think the important message to pediatric community, we all have to work together to make it happen early on, because it's so much more effective, so much more faster in terms of the length of the treatment, that intervention that we are doing, and also it prevents from brain to go in the wrong pathway. Some things we really cannot reverse, and that's unfortunate. That was a summary of what already in place. It's right now we are up and running, and we will be able to see more patients and have more referrals of children who have experience of toxic stress, and it was really important for us to start with this point. But I want to share with you that the ideas about how to go forward and potentially maybe working with other clinical populations. That here in the Department of Pediatrics we're seeing. If we think about, and I was thinking about that it can be done by, several steps. First is important to identify what is the main point of entrance. For example, when we talk about toxic stress or deprivation, it definitely right after we identify this child. That's very important. When we talk about the group like, for example, children low birth or premature children, and when we can think about the most effective point of entrance may be time of birth, because that's when the child first time to start to be part of the environment, and that's where for parents are particularly important to be a regulator and help a child to develop full capacity to regulate their behavior and emotions. And the second step is build the program on what we already know and continue to do research on the questions that help us to move forward. Again, it's a really fast-moving and developing field. We really think that in the next years we'll be working potentially very different from now, because, for example, when we learn now about executive functions, new intervention are moving us really fast in a wonderful new direction, and I will expect that research that we are doing also will help us to modify the program. For the future research, I just want to mention my wonderful collaborators who I am working for years, for some just started to plan to work, who are helping in this research bill, really instrumental in developing this program and really raising the issue of this is not about only mental health, it's also about the health and the physical growth and nutrition, and we really need to work together to help these young children to develop to their full potentials. The studies done by Michael Georgiev and Sarah Kuzik on nutritional status and neurodevelopment. We hope to continue to work with Dana Johnson and Dr. Eckerly on the understanding health development of particularly deprived children, understanding the impact of physical growth of wonderful colleagues, Brad Miller and Anna Patrick and John Himes. We continue planning to work with the Center for Neurobehavior Development and with my colleagues, including Megan Garner, on understanding stress-sensitive system, because as you understand, it's really critical for us to understand how it works for a young child, what we can do better, what we can learn to make the programs that we are proposing here working better. The new part of research that we are really excited, starting the work with Jed Allison, my colleague from the Institute of Child Development, and we started to think about the modifying and making the program for intervention for executive functions and emotional regulation, and this work will be done with Dr. Samrud and Dr. Zelaza at the Institute of Child Development. There's a lot of exciting ideas, and I wanted to first focus on what we can do now and how you can refer. Hopefully you will hear about research more and about more clinical programs in the future. Any questions? The intervention. What? It's a good question. It's like my son when he was young, his hypothesis was that I'm opening the brain and fixing brain and clothes, and it was his hypothesis. No, we don't do that. Yeah, educational component is important, But I think for the 0 to 3, the most effective interventions is basically you're working on parent-child relationship through observation of this relationship, with pointing parents to child's behavior and the positive behavior on the side of the parent, helping them to see different picture. You know, like from the just aggressive child who cannot stop running around, bouncing to the walls. Usually my goal for the first meeting that this parent will go away with a feeling that, oh my God, this kid was really scared. I could help him. Does it make sense? You helping to I sometimes tell parents, I don't do anything, I'm just interpreting. I'm just here plain interpreting your child to you, and I just learn your child's language because of that's what I do. I don't know if I answer your question, but the other piece that I didn't talk, and this is a big piece, is working with parents themselves, because we have many parents with trauma who have their own trauma. And that's why parenting is really difficult. What we can do here, we provide help here or refer to adult psychologists. But that has to be, again, on the table, and we need to discuss this. That's another piece.
Maria, I think one of the things that I think we do well in terms of working with parent piece is, you mentioned earlier, kind of keeping the parents in a zone where the kids don't get too high and too low. And a lot of what we have with these kids is the parents react very much to the behaviors, and helping the parents to parent a little bit more neutrally. I think that's what you do really well with these parents in terms of the direct skill development of not emotionalizing the kid's behavior quite so much and getting them into a zone where you can be more task focused, a little bit more kind of proactive in reset and escalation, or helping the kids to see where those bumpers are. Right? And starting with the parents to get them to a spot where they don't react quite so much, and is kind of the first step typically, while we then move into the next stages of it. So I think that's one of the things that you do, you know, when you're working with the parents, is teaching them how to respond to the child's behaviors, and not always trying to go on top of the behaviors, and the parents get kind of wacky with the wacky behaviors, and so teaching them how to contain. That's a clinical term too. Wacky are clinical terms.
And I think, as I said, Chris absolutely right. It's a very important part, and I think that it's really exciting for me that the field is going there, recognizing that treating a child doesn't get us far. Helping your parents to be more regulated. And again, if we think about this interaction between the parent and a child in the video, this mom is pretty regulated herself, correct? If you think about an anxious mom in front of the camera who has, you know, like, and she will have a child who compromise for different reasons, then you will not be able to see this. And it's both bringing the parent down and helping the parent to hear a child. I really like to say parents, we need to listen to our children. It's sometimes very hard, but and that's what we can help them when they're coming to us.
This is very interesting. Critically, it strikes me that this is where we were when we built the Denver Developmental Assessment exam for pediatricians who are not specialists. Do you have a tool like that, or developing one that general pediatricians or practitioners can readily utilize to have these developmental stages to identify this issue?
We probably can develop a list of the, as I said, red flags in terms of where that definitely, and I think that would be my next goal, that I will be sent to pediatrician, that it will be as a reminder in available for medical students and residents to look. Definitely it's a next goal, and it's a great suggestion. Mm-hmm.
I work in a world now where we take care of kids with chronic illness, and the treatments that we use cause toxic stress to children birth to 3. symptoms, that faces that look like that?
And as I said, we don't have enough research about that, but clinically I will say it's a toxic stress there, and particularly if we stress a parent, and parent can hold stress, then no buffer, and it becomes really, yeah, definitely 0 to 3, we will be happy to see these parents, yeah. Mm-hmm. Thank, uh-huh. Mm-hmm. Sleep disorders are very common. It's probably one of the most common issues in the kids with toxic stress, and something definitely can be addressed through intervention we are working, unless there are other reasons for sleep issues that Yes, sleep is a huge piece of the puzzle. It goes both ways, correct? You know, like it's improvement of behavior before sleep, improve sleep, improve behavior. In dysregulated children, it's so typical, and I do see probably sleep takes longer than any other pieces to improve. For multiple reasons, I suspect. But when children, you know, like, and I don't have time to go in whole theory about the sleep, but we sleep when we are safe, correct? You know, like they're one of the, you know, and this is the major issue that we can address with 0 to 3 kids, to think about how make them more safe. And again, listen to your child, think through how it works for a child, more regulated and more safe. Yeah. Thank you.